This program is brought to you by Emory University.
Morning, everyone. Welcome, and join me in welcoming David Markham as our speaker today. Many of you know David's an associate professor in the Division of Cardiology and heads up our advanced heart failure group based at Emory St. Joseph's Hospital. David came to us from UT Southwestern. He did his medical school here at Emory, did residency at UVA, and did fellowship at Duke and UT Southwestern, and been on faculty there for several years before joining us. Today he's going to talk about what I think is one of the more devastating and fascinating cardiomyopathies, and he has some unique experience with that he's going to share. So David, welcome. Tell us all about peripartum cardiomyopathy.
Okay, well, it's great to be here again. This is a fascinating topic, and my job is to convince you that it is one of the most fascinating areas, but we have a long way to go in learning what is actually going on with these patients. However, in the last few years, we've learned some interesting new things that I will present to you. I want to dedicate this talk to a couple of my friends and mentors. I think during our careers, we're all grateful to have wonderful mentors, and I've had many, but two of them are here. And they have had me involved in the Haiti Peripartum Cardiomyopathy project. On the left there is Dr. Jim Fett, who probably many of you know. On the right is Bob Caraway. They were both medical directors at the Albert Schweitzer Hospital 15 to 20 years or so ago, and recognized that Haiti was having one of the highest incidences of peripartum cardiomyopathy in the world, and we've learned a lot from these studies and their writings and teaching in the last 20 years or so. It's hard to mention Haiti without mentioning that we just had the 6th anniversary of the earthquake, which happened on January 12, 2010, and so this is one of the worst human disasters in world history, with about 300 to 400,000 people dying in one instant. And so I also want to dedicate this to the people of Haiti, and particularly the women of Haiti, who have let us learn a lot from them for peripartum cardiomyopathy. We're going to go over a few topics and questions during this talk. First, what is peripartum cardiomyopathy and how often does it occur? What is the clinical course of patients with peripartum cardiomyopathy? What are the possible etiologies? And it's impossible to go through all of the different hypotheses in this area, but I'll go over a couple of the more pertinent ones that have arisen recently. How might peripartum cardiomyopathy be related to dilated cardiomyopathy? This might be the core of what I'll talk about today. What is the treatment? And then one of the most important questions is, should peripartum cardiomyopathy patients become pregnant again? Now, peripartum cardiomyopathy was first recognized in the 1700s. I actually looked back in Paul Dudley White's heart disease, and there's not a lot of mention there. But one of the first modern descriptions came in 1937 by a physician named Gooley, and described a case series of patients. And this is often referred to in this area. It's a rare cardiac disorder with good prognosis overall compared to most other types of cardiomyopathies. And I'll go over some of the data about that in a few minutes. It's one of the leading causes of maternal death, but the etiology remains unknown at this time. And the disease affects the entire community, and you particularly see this in poor places in the world like Haiti, where if a mother dies, of course, then there are orphans, and then the community is left to handle children. And so it's important to protect the health of all mothers, and this is one of the things that I've enjoyed most in traveling to Haiti and working with Drs. Fett and Caraway and all the Haitian physicians there to help protect women's health. Now, there are many definitions of peripartum cardiomyopathy. Some are narrow and some are more broad. If we go back to 2000 on the left here, The workshop from the NHLBI defined this disorder as the development of heart failure in the last month of pregnancy or the first 5 months postpartum without an identifiable cause of heart failure, and then EF needed to be less than 45%, essentially. And this is what I was always taught in med school, residency, and fellowship. There's a 6-month period of time, last month of pregnancy, 5 months after, where you really feel that you're confident in making the diagnosis. More recently, many of us feel that the diagnosis criteria should be a little bit more broad. So in 2010, it was revised. This is the European Society of Cardiology Working Group, where PPCM is an idiopathic cardiomyopathy presenting with heart failure secondary to LV dysfunction towards the end of pregnancy or in the months after. Not a strict criteria there. It's a diagnosis of exclusion with an EF of less than 45%. And so I think this will continue to be revised as we go forward, and I'll show some of the more specific data on this in a minute. Of course, the heart failure symptoms in pregnancy can be difficult. Things to look out for include dyspnea on exertion, cough, orthopnea, P&D, chest pain, edema, and fatigue. But to think about getting an echo or working someone up for peripartum cardiomyopathy, you have to have a high degree of suspicion, because each of these can mimic the symptoms of pregnancy, of course, particularly the lower extremity edema and so on. So we can't necessarily echo every pregnant woman in the world, but if we hear of patients and have a high degree of suspicion, it's a proper time to consider an echo or other workup. Now, the incidence and prevalence is highly variable around the world, and this is one of the mysteries of this disease. In Haiti, it's almost it seems every woman you echo has LV dysfunction. It's not quite the case, but the incidence is as high as 1 in 2 to 300 by estimates. It's incredibly high. In the U.S., the incidence is about 1 to 3 to 4,000 live births. Japan, 1 in 6,000. South Africa, they've done a nice job in South Africa writing and learning a lot about the cohort there, where it's estimated about 1 in 1,000. And then there's the high prevalence in Nigeria with ingesting kanwa, which is dried lake salt. And this becomes very interesting. This cohort of patients has arisen from the Hausa Fulani population in Nigeria, and it was discovered that about 1% of deliveries were followed by heart failure. This was 10 times the incidence compared to other parts, even in Africa. It was most common to have this diagnosis between June and October, which is the hot and rainy season, and it's associated with cultural practice. And this is from an article back in the 70s where they say for 40 days or more after delivery, the traditional Hausa mother does not leave her compound and lies twice daily for hours on a baked mud bed over a fire, which makes her hut very hot. She splashes herself with scalding hot water and eats highly spiced food laced with kanwa, or dried lake salt. And so a group of people clued in on this and did some hemodynamic and echo studies, and one paper came out many years ago where if you look at the quote-unquote PPCM mothers versus controls in the same community, the EF there was about 50% in cardiomyopathy patients versus 70%, and it seemed to be more of a high output type of situation. And so this might not be fitting into our traditional criteria for PPCM. It might be something completely different, more related to vasodilation and maybe this salt loading and so on. But if you look around and study PPCM, these women in Africa are referred to quite often, the Hausa Fulani patients. Now, the timing of PPCM also varies by geographic location. If you look on the left here, in South Africa, the typical time of diagnosis is within the first 3 months postpartum, with some patients being diagnosed 3 to 6 months postpartum. In Germany, it's a little different. And then if you look at the right in the United States, most patients, 73%, are diagnosed within the first 1 to 3 months. and then about 24% are in the first few days, or right around the antepartum period. And certainly, I think we see this in our own practice, where we'll get calls for patients who have their baby and within the first day or two have shortness of breath and have very low ejection fractions. This is also goes back to the timing of diagnosis, which I present here. If you think back about the first or the last month of pregnancy being a time of diagnosis, in the first 5 months, it can't be a strict criteria, because in this paper, which comes from Yuri Elkayam, in 123 patients, the diagnosis can be made even before or even after that. And here you see on the left side where some patients were diagnosed early with peripartum cardiomyopathy. Most patients, the 75, were diagnosed right around the time of delivery, but some patients were even diagnosed 4 or 5+ months. And of course, this depends on a lot of things, not only in the United States, but around the world: the severity of the heart failure, access to care, the clinical suspicion that we have as providers, and of course, it's a diagnosis of exclusion. And so, now the proposed risk factors have been also sort of sketchy and debated a lot. One of the most common ones that's discussed is multiparity. It turns out that this is probably not a true risk factor. It hasn't been borne out in more recent studies, but patients who are older or really younger, for instance, less than 20 and greater than 30, have a higher incidence of developing peripartum cardiomyopathy. One of the things that's been borne out as a risk factor for the development of PPCM is multiple gestation. And so as we've seen in the last 20, 30 years in our country, with more 2, 3, 4 babies born at a time, those patients are at higher risk. And we'll talk about the risk that goes along with different types of hypertension. Gestational hypertension. Preeclampsia gets very interesting, and I'll present some of the data about that. Tocolytic therapy is a questionable risk factor. Dr. Fett and others have recommended that vitamin deficiencies like selenium may be a risk factor, particularly in poor parts of the world where this has been looked at, but there's not a lot of data about that. Definitely African racial background is a major risk factor. We'll have just a couple minutes to talk about that as well. Now, the major causes of death for peripartum patients includes progressive heart failure, pump failure, arrhythmias, and thromboembolism. I want to quickly show a little bit of the data there about the outcomes for each of these. One of my friends who I trained with, Mike Felker, a long time ago published this article in 2000, and this compares the outcomes for different types of cardiomyopathies. And you see here at the top of the slide, peripartum cardiomyopathy perhaps has one of the best outcomes if you take all comers, with at 10 years, 80-90+% of patients doing quite well. And we see that to this day, and probably the outcomes are even better than they were 10 or 20 years ago because of the sympathetic blockade and so on. In the middle here, it's important to see that the cardiomyopathies that don't do as well are idiopathic cardiomyopathies, ischemic cardiomyopathies, chemotherapy-induced cardiomyopathies, and at least at this time, back almost 20 years ago, HIV cardiomyopathy was not associated with nearly the outcome, and that has changed, of course, in the last many years. Now, if you look at the data for outcomes, the mortality ranges for different time periods between 0 and 56%, and I've listed some of the different studies here. In 2000, a important paper, Pearson, looked at about a 50% survival at I think this was about 1 year or so, where he noted that survivors had a higher ejection fraction and smaller cavity size. And one of the things that has come out many times in studies of PPCM is that if the ventricle is greater than 6 centimeters, that's one of the factors that definitely points toward a worsened outcome. And so as patients are referred to me, what's definitely one of the important factors, not only the ejection fraction, but the size of the ventricle being greater than 6 centimeters. You see here more recently, some of the outcomes have been in the single digits to the teens or so. As I said, if LV dysfunction persists after 6 months postpartum, the mortality may approach greater than 50% at 5 years, but recent outcomes are improving. So we seem to be doing better as far as we can tell. Now, one of the most important recent studies was the IPAC study, which a bunch of folks around the country were involved with. This came out last year. This was a follow-up of the IMAC dilated cardiomyopathy study. So you have to stick with an acronym that's kind of close to the same, IMAC, IPAC. But this was the pregnancy-associated cardiomyopathy study in North America, where various centers enrolled patients for 1 year with PPCM. So 30% were black, 65% white, 5% others, so a sort of a diverse group. Mean age was about 30, and one of the most important things that came from this study that I'll present in a minute was that samples were collected. So DNA was banked, and serum and plasma were stored so that various biomarkers could be looked at. And I'll show you a couple of the figures here that came from this. So this is the modern, most recent big outcomes study for peripartum cardiomyopathy. If we define events in this 1 year period, including hospitalization, death, transplantation, or implantation of an LVAD, we saw that patients who had an EF less than 30% had about 15-20% outcome rate, event rate, compared to patients who had a pretty good ejection fraction. This was sort of to be expected. The baseline echo was quite important, not only for the diagnosis, but also for the prognosis. And it's one thing that continues to come out in all of our studies. If we look at the ejection fraction and the outcomes a little differently, we see that patients here on the left with a low ejection fraction, less than 30%, about 37% or so had an event or at the follow-up time remained with an EF less than 35%. 26% of those patients had somewhat mild recovery, mild to moderate recovery, where their EF improved to the 30s or 40s, and then 37% had improvement to an EF that would be about normal. If at the time of diagnosis the ejection fraction was greater than 30%, almost all of those patients had complete recovery. So this was quite important to note. Now, one of the things that has come out in Dr. Fett's data from the Albert Schweitzer Hospital in Haiti is that over time, recovery can take much longer than a year. So if patients are tracked, this was 32 Haitian patients in the 2000s, and we see that many of these patients had a curve that sort of looks like this as far as their recovery, with some patients taking up to 2 to 3 years. And this becomes important, as I'll also mention in a few minutes, with decision about placing a defibrillator, because some of these patients, particularly if they have LV dysfunction and don't get pregnant again, can recover and may not necessarily require ICD placement. So what does this look like in the IPAC data? If we look at over time, at least over a 1 year period of time, comparing non-black versus black patients, we see that the recovery rates are a little lower with regard to ejection fraction in patients of African descent or mostly African Americans in this study. And you see that the curves are a little bit different. And again, this has been borne out many times. As I've said, reversal of LV dilation is quite important. This goes back to the early 70s. If you have cardiomegaly or a dilated left ventricle at 6 months, follow-up of 10 years, no cardiomegaly, then in this early study, about 2 patients out of 14 died, and both of these were actually non-cardiac. Going back to 1971, if 6 months time period went by and there was still LV dilation, the risk of dying was 85%. Probably much different now in our modern time, but dilation is quite important. Dr. Fett and I recently put this together after the IPAC study came out, looking at various studies over time, comparing what patients looked like if they recovered or did not recover. So here I just want to focus on two of these. One was an earlier study by Dr. Fett looking at, on the left there, recovered patients right here who had an EF starting a little bit higher than the non-recovered patients, 28% versus 23%. And here, 27% of these patients recovered versus 72%, whereas if you look back at the IPAC data more recently, 65% patients recovered versus 35% in modern times, and these numbers are much different. So the higher your ejection fraction starting, the more likely you are to recover. The lower your ejection fraction starting, the more difficult it may be to recover. So these have been borne out in many studies. And one more piece of data from Dr. El-Kayam, who has been a leader in this field for a long time. This is 123 patients with PPCM, and in this data set, which is often referred to, there was a recovery of complete function of LV function in 59%, persistent LV dysfunction 41%, and about 4% needed heart transplantation, 10% died, including two patients who died after a heart transplant. So this is often a good data to refer to as you see these patients in clinic and so on. Now, with regard to arrhythmias, I alluded to this a minute ago. There are limited data with regard to arrhythmias, only a few case series, and we don't have real guidelines to support placement of ICDs at a particular time period. Most people follow our other heart failure guidelines for defibrillator placement, but there was this one article that came out a couple of years ago just looking only at 12 patients with a mean follow-up of 81 days, and these were patients wearing a wearable cardioverter defibrillator. And of these 12 patients, 4 of them, actually 3 patients had 4 events of VT and VF in just a short period of time. And over time, all of these patients, all 12 of them at least, had improvement of their ejection fraction. Now, I think 2 of these patients in this case series had secondary ICDs placed and so on, but it remains a big debate about when to place a defibrillator in a young woman who perhaps is in their 20s or 30s, who may recover over a period of 1, 2, 3 or more years. So now the other problem that is quite common in patients that leads to a lot of mortality and morbidity is thromboembolism. This goes back to early data looking at a high prevalence of PEs, systemic embolization, and stroke. You can see the rates here, but there are numerous other case reports looking at peripheral and coronary emboli and so on. And it's a difficult problem because you really have the intersection of 2 hypercoagulable states with heart failure, LV dysfunction. We see an incredible amount of low flow in Haitian women with very big hearts, and it's difficult to anticoagulate patients in Haiti, as you can imagine. But then they go through pregnancy or repeated pregnancy, and you have the hypercoagulable state of pregnancy as well. So it's very sad to see some of these young women who are pregnant or right after pregnancy have strokes, and this remains a big problem. There are no specific guidelines, again, about anticoagulation, but in my particular thinking and practice about this, I tend to anticoagulate women for a certain period or some period of time, particularly if they have a very, very low ejection fraction because of data like this. But there certainly is not a consensus on that. So now let's talk about what is this disease. I've tried to go over a few of the initial introductory pieces of what peripartum cardiomyopathy is. But let's now talk about some of the hypotheses about what this is. So a few of the hypothetical etiologies of peripartum cardiomyopathy include autoimmunity. Is this an autoimmune disease? Is this a infectious or myocarditis sort of problem? Is it related to oxidative stress or apoptosis, abnormal angiogenesis, or could it be related to genetic sarcomeric mutations? I don't have time to really go over a lot of the data for autoimmunity and myocarditis, but suffice it to say for now that if you biopsy a lot of peripartum cardiomyopathy patients, you see a very low level of pathological diagnosis of inflammatory infiltrate suggestive of myocarditis, about the same level that you would with a dilated cardiomyopathy population. It's not zero, but it's in the 5 to 10 to 12% range where you might see an inflammatory infiltrate if they're biopsied at the right time and there are enough pieces and so on. And so also along those lines, if you PCR tissue and look for or do viral testing on patients newly diagnosed with PPCM, you have about the same amount of diagnostic criteria for viral infections in PPCM patients versus dilated cardiomyopathy patients. So it's really murky and becomes very complicated quickly. So I'm going to mainly focus on some of the more recent data that involve each of these different categories. So one of the more recent interesting pieces of data comes from transgenic mice from a few years ago, looking at the STAT3 pathway. So in these STAT3 transgenic knockout mice, the mice had normal pregnancy-induced LVH, but it was noted that in the hearts there was a loss of capillaries, there was increased apoptosis, fibrosis, and over time a dilation of the left ventricle. And this dilation was blocked by bromocriptine, which is the dopamine D2 receptor agonist. So it's known that STAT3 signaling is normally cardioprotective and is a powerful antioxidant. And it's also known that during pregnancy, oxidative stress increases. And it turns out that prolactin activates STAT3. But when you get cleaved prolactin, as I'll show on the next slide, cleaved prolactin, the 16 kilodalton version of prolactin, is pro-apoptotic in angiogenesis. Long story short is that particularly the group in South Africa looked at a lot of this data and did a lot of this research and thought that bromocriptine, as a blocker of the prolactin pathway, could potentially be a treatment, and that maybe an abnormality in the STAT3 prolactin pathway could be etiologic or pathologic as far as promoting this disease. So here's a schematic of this, where you have the pituitary gland releasing 23 kilodalton prolactin, and the 16 kilodalton prolactin version is detrimental. And if you, in the transgenic model, if you block STAT3 and affect cathepsin D, you basically develop a system where there is increased apoptosis and possibly angiogenesis in at least this mouse model. The group in South Africa looked at this and saw the oxidative stress, implicated STAT3, cathepsin D signaling, and showed that that patients with peripartum cardiomyopathy have high levels of this 16 kilodalton version of prolactin, and began writing about it. It turns out that it's unclear, even to this day, why STAT3 might be dysregulated in humans, compared to these transgenic mice. But polymorphisms in STAT3 have not really correlated with the disease. And in South Africa and around Africa, the group has taken patients and given them bromocriptine, at least in a small number of case series, and they showed a possible benefit. But because of the problems with bromocriptine as a drug itself, this treatment has not really taken off, and is still limited to mostly case reports. We still get a lot of calls. every so often we'll get a call. We have a peripartum cardiomyopathy patient here. Should we give them bromocriptine? And my typical answer is no, we should not give bromocriptine. It has its own problems, and the data haven't really been effective, haven't been shown to be of benefit. But that's a question that we will get occasionally. Now, we'll come back to that in a minute. The other line of research recently has involved this, and it starts with the story of preeclampsia. Preeclampsia and peripartum cardiomyopathy have a certain amount of overlap. So if you look at this study from a couple years ago, looking at the prevalence of preeclampsia and peripartum cardiomyopathy, you see this line. This is a meta-analysis where we have about a 20 to 30% overlap of patients with PPCM who also have preeclampsia. This is the background prevalence of preeclampsia in the general population, which is 2 or 3% or so. And so for many, many years, for decades, people have wondered what the connection is. And it remains largely explained, but we may have a new insight into this. So up to 1/3 of PPCM patients may also have preeclampsia. It turns out that any form of hypertension in pregnancy has a higher proportion of patients with PPCM who eventually will recover. The patients have a low ejection fraction, LV dysfunction at the time of diagnosis, but they recover fairly nicely, at least in this population of people. And as I want to talk about next, serum FLT1, FLT1 levels are associated with preeclampsia. And it's unusual and it's mysterious that preeclampsia causes cardiac dysfunction independent of what the blood pressure is. And we don't really understand why that is. But this may be helpful here. In a recent paper that came out in Nature, mice were deficient in PGC1 alpha, which is a regulator of angiogenesis, were studied. And it was found that these transgenic mice had high levels of FLT1, which is this marker of angiogenesis that's released from the placenta, and correlated with LV dysfunction. You can see here that compared to controls, the PPCM, and by the way, there are several mouse models for PPCM. This is only one of them, but they did have high levels of sFLT1. Turns out that in humans, the placenta secretes these. This is a VEGF inhibitor like S1, and it's accentuated. So people who have multi-gestation or preeclampsia have very high levels of sFLT1. So this has recently been discovered and looked at. It turns out that in the transgenic mice and in humans, high levels of this marker are associated with LV dysfunction, dilation, and even diastolic dysfunction. And one of the most important parts of this one study was that diastolic dysfunction was one of the biggest markers of this, which also remains sort of unexplained. Now, one of the groups that comes to the Albert Schweitzer Hospital in Haiti got a number of samples recently in the last couple of years looking in a preeclampsia population, not the PPCM population that we look at, but in another group of preeclamptic young women, and showed that the ratio of sFLT1 to placental growth factor is quite high. And so we're just beginning to learn about this. We haven't yet studied this marker in PPCM patients, but it particularly points to a marker of decreased angiogenesis, VEGF inhibition, as a problem that comes from the placenta, affects the heart, and points to this possible two-hit phenomena. So I want to describe now what we may be seeing, and the authors of these data make a good argument currently with regard to this hypothesis, and that is that these results of this marker being elevated toward the end of pregnancy, but really elevated in preeclampsia and so on, point to maybe a two-hit phenomena that could cause this disease. First, you have systemic anti-angiogenic signals that normally occur in late pregnancy, are associated with oxidative stress, but for whatever reason, in some patients are dysregulated. And then perhaps in humans, there's a genetic predisposition or some sort of intolerance to cardiomyopathy and oxidative stress that exacerbates this problem. We can't completely explain the development of PPCM based on sFlt1 levels being high, but it may be that there are other genetic or other susceptibilities, perhaps infection and so on, that make people more prone. And that might also point to geographic variability in the incidence and prevalence of this disease. So here we have a scheme that again comes from the South African group, where we have the placenta releasing high levels of sFlt1. This is a very exciting marker that a lot of people are looking at now, affecting microcircular homeostasis. And it combines in this schematic the prolactin pathway. So you have this pathological 16 kilodalton prolactin, perhaps maybe being blocked by bromocriptine and maybe with some potential future benefit. But you have a problem with oxidative stress and anti-angiogenic factors in the VEGF pathway that affect the heart and make people more prone to this problem. And it becomes very, very interesting. So the last thing I want to point to with regard to potential hypotheses is that is the question of whether there is an overlap between genetic forms of dilated cardiomyopathy and PPCM. And I'll do this fairly quickly. There's new data on Titin, which is one of the major three filaments in the cardiac sarcomere. The Seidman group just recently came out with a New England Journal article comparing IMAC patients. Again, these are the patients that were studied a few years ago with dilated cardiomyopathy and IPAC data. So the patients with peripartum cardiomyopathy that just were published, the 100 patients with peripartum cardiomyopathy. And what they saw, I don't know if you can see this extremely well. This is the sarcomere here, and this is these are the different regions of the Titin molecule, which is the largest human molecule of any kind. And you see here in the peripartum cardiomyopathy patients, there were a number of mutations that were discovered within the A-band region. And this correlates to dilated cardiomyopathy patients that were previously studied by the Seidman group, looking at a number of mutations also in this region of the gene. And so if we look closely at this, the IMAC patients from many years ago, we got small numbers of patients, 34 people who were in their 30s compared to about the same age for IPAC. About 32% of patients in IMAC2 were of African descent. About the same in IPAC, where about 30 patients or so were African American. The EF at the time of diagnosis was about 30%. And here we have a very important and striking finding where in each group, dilated cardiomyopathy and peripartum cardiomyopathy, we've got about a 10 to 15% rate of mutations in the Titin gene. And so going back to that two-hit hypothesis, it may be that there's certain genetic predispositions with sarcomeric proteins that again follow in this line that make people more prone to developing cardiomyopathy at the time of pregnancy. Now, it remains mysterious because we're still only talking about a small number of patients who actually have these types of mutations. And so it remains, we have to do a lot more study in this area. Of interest, though, there were several other patients who had, in IPAC, in this Seidman article, who had mutations in the Duchenne muscular dystrophy gene, for instance. And of course, the number of mutations in other proteins would go on and on if we had thousands of patients, but we don't have thousands of patients to study right now because it remains a fairly rare disorder. One other recent paper just came out, and again, this is from IPAC, where they looked at the guanine nucleotide binding protein beta 3 subunit. This is an important genotype that came from the AHEF study. So if you remember in the AHEF study, African Americans have been known to have a high rate of this genotype with the C genotype, and which it turns out that this genotype allows is associated with higher levels of hypertension and also higher levels of cardiomyopathy. And in the IPAC data, in the peripartum population, as you can see here, this is African American folks on the left, the women on the left here, and white on the right. There are higher levels of the C genotype in patients who did not recover versus those that recovered. And so we got a lot more to look at here, but this genotype appears to be associated with, again, part of this picture of genetic areas that could be markers for risk. So now I want to switch over in the last few minutes to talk about treatment. Pre-delivery, I think everybody has seen slides like this before, but it's useful to remember that pre-delivery in pregnancy, there are some safe medications that can be used for afterload reduction. For instance, hydralazine and nitrates. As far as beta blockers goes, we'll often use carvedilol or metoprolol. Diuretics can be used. Digoxin, inotropic agents can be used if needed. Aldosterone antagonists and heparin. But most of these are category C. Unsafe medications that we steer away from include ACE inhibitors, of course, Coumadin because of the teratogenicity, amiodarone, and Coumadin and statins. So postpartum, there is a complete lack of randomized clinical trial data. So we mostly rely on heart failure standard guidelines using the typical food groups of heart failure, ACE inhibitors, beta blockers, diuretics, and digoxin. And if patients, this has to be steered directly towards specific patients on whether or not they want or need to breastfeed or not, which becomes an incredibly important part of management, particularly in poor parts of the world where we do want them to have breastfeeding. Now, particular considerations for postpartum period include high rates of thromboembolism. We have to consider warfarin, at least in some of these patients, particularly if they seem to be high risk based on imaging. A lot has gone into the study of other immunosuppressive agents or immunoeffectors like IVIG. There aren't many data on this, but in the peripartum world and also in the myocarditis world, IVIG has not been shown to be effective with beneficial improvement of the ejection fraction over time. So it's largely not used. There have been small studies of looking at pentoxifylline in Haiti and South Africa, and those studies were also negative. With regard to bromocriptine, going back to that, I alluded to a small study in South Africa a few years ago that gave 5 milligrams a day for 2 weeks. This was in 10 or 15 patients or so. And the idea here was that prolactin is upregulated in the postpartum period to induce lactation and may be implicated in this oxidative stress sort of pathway, as I described earlier. But there are few data. It's really at the case report level, and the data are underwhelming. However, the group in South Africa are teaming together with a group in Germany and other places in Europe to now study this a little bit more effectively. And I just wanted to show here that the goal is to randomize 60 patients in the next year or two and have a treatment group and a control group. And the primary endpoint of this study will be an improvement of ejection fraction. And my guess is this will be negative, but we'll see. I still don't recommend bromocriptine at the present time to be routinely given. And most of the patients who are quite ill with peripartum cardiomyopathy, for instance in shock and so on, need to be considered for transplantation or other sorts of advanced therapies, including mechanical support and so on. Immunosuppressive therapy is not really in favor. This goes back to the 1995 myocarditis treatment trial where 111 patients received immunosuppressive therapy, and there was really no benefit. There were no peripartum cardiomyopathy patients in this study. But I point this out because these areas of research overlap. between inflammatory processes and peripartum cardiomyopathy, at least hypothetically, and we have a lot to learn with that. So the NHLBI recommendations on this state the following: that immunosuppressive therapy can be considered if an endomyocardial biopsy indicates myocarditis and there is no improvement after 2 weeks of standard heart failure therapy. So, at least in some patients, it might suggest that a biopsy should be done at 2 weeks if the patient's not improving, or if there's a fulminant sort of decline with heart failure and so on. I haven't biopsied personally a lot of peripartum patients, but this is one of the ideas. So, for patients who are really failing, we really do aggressive attempts to support patients long enough to allow recovery. So some patients can be considered for inotropic therapy, and we've had a number of patients who require LVAD placement or even cardiac transplantation. The transplant data are interesting because a few times in recent history, folks have plotted and looked at the outcomes data for young women with peripartum cardiomyopathy, and they're really quite good. They're quite similar to other types of heart failure. You see here ischemic cardiomyopathy over the first few years after transplantation, and they remain quite good. There is a higher risk of early rejection in transplant patients with PPCM, and that goes along with patients being typically a younger population. And so, but I wanted to show this data that transplant outcomes can be quite decent. So the duration of medical therapy, if we go back to our typical beta blocker, ACE inhibitor, and other heart failure regimen for these patients, this remains a hot topic of debate. So how and when should we wean heart failure medicines after a recovered patient goes along? Data from Haiti would suggest that some patients recur after many years, and it seems like every time I go to Haiti and work at the Schweitzer Hospital, there are a few patients that are 10, 15 years out, originally diagnosed by Drs. Fed and Caraway, who have been off medicine for a few years, and they're back with heart failure, and they haven't had a baby anytime recently. So why this happens is a mystery. But I tend, because of this data, both in the States and elsewhere, I tend to leave people on as long as I possibly can, even if they're mostly recovered. I don't know if that's right. I think if you poll, the IPAC group, we met and debated this a lot. Some people take people off at a year or two if they're recovered, but it's hotly debated, and we can even debate that now. But it's a lot of data needs to be developed in this area. So in the last few minutes, I want to talk about, is it safe to become pregnant again? The ability to safely undertake a repeated pregnancy is related to whether there was complete recovery after the initial episode. If you look at this data, so the patients who had peripartum cardiomyopathy are thinking about becoming pregnant again or whatever, they have an EF of greater than 50%. They have a pregnancy, and in this analysis, their EF dropped a little bit. There was about a 21% rate of having clinical heart failure, no deaths, 11% rate of premature delivery, and 4% terminated pregnancies. Now, if you didn't recover and you become pregnant again, this is, again, small numbers of patients, but the EF was lower and went lower. There was, again, about a 20% rate of recurrent heart failure, about a 20% rate of death, 30% rate of premature delivery, and so on. So, again, the marker of LV recovery is quite important. And so here's my take on this, and this is what part of what I will typically tell women who are referred in to consider this issue. If I have a normal ejection fraction and want another pregnancy, what are the data? So if the EF is normal or not, EF may decline with another pregnancy. EF declines in about half of women, who, even if there is a normal ejection fraction, and about 23% had a decrease in subsequent pregnancy, but death is very rare. So it comes down to a discussion of you could easily have heart failure, and you could easily have LV dysfunction again, but you're probably not going to die. And so if patients really want a subsequent pregnancy and their EF is 60%, this is what we discuss, and then we discuss monthly echoes and so on. This is a much different situation if you have an abnormal EF and want another child. So heart failure symptoms, at least in some studies, are twice as likely to occur. You can have a much higher risk of mortality and lots of problems. I've had a few patients who, with a normal EF, also have arrhythmias around the time of the antepartum or postpartum period. And so this is essentially the data that I share with people in counseling. The other part of this is that there can be a subtle finding related to the contractile reserve. So if you have a patient who is completely recovered imaging-wise after having, for instance, mild peripartum cardiomyopathy with a prior pregnancy, some places and some investigators recommend doing a dobutamine or an exercise echo looking at contractile reserve. Some of these patients will have subtle findings of impaired contractile reserve, and that goes along with a slightly higher risk of developing heart failure or having a relapse of peripartum cardiomyopathy, as seen here, compared to patients who have normal contractile reserve. And I've very frequently referred patients to have an exercise echo. If it's completely normal, then we feel a little bit better about that if they want to really work towards having another pregnancy. So if your echo is normal, we consider a dobutamine or an exercise echo. If left ventricular dysfunction persists, if your EF is not normal, then pregnancy should not be recommended. If a normal echo, if the echo is normal but there is decreased contractile reserve, the patient might not tolerate the hemodynamic stresses of pregnancy, but it could be considered, a repeat pregnancy could be considered if there's full recovery and normal contractile reserve, but it's not without a zero risk. And so in conclusion, peripartum cardiomyopathy is a rare disorder, at least in the US, but this translates still into thousands and many thousands of patients per year that usually present right after delivery. There are divergent outcomes in this patient population related to whether you have recovered LV function or persistent LV dysfunction. And progress in understanding this etiology, the etiology of this disease has been slow, although in the last 2 to 3 years we've learned a lot related to oxidative stress, apoptosis, genetic mutations, and so on. So one of the big things I want to leave you with again is this idea of is this a two-hit or a multi-hit phenomena? Do we have the abnormal angiogenic factors that are perhaps genetically determined to be more active in some populations, and that's combined with a risk of being more prone or not being able to tolerate the hemodynamic or the cardiomyopathic processes of pregnancy or right after pregnancy. And those relate to the things that we discussed. The standard heart failure therapy should be used, beta blockers, ACE inhibitors, and so on, but bromocriptine is not really ready for prime time. Anticoagulation can be a very important part of this. And again, recovery of LV function has an important prognostic value and is a key factor in whether subsequent pregnancy can be considered. So we've learned a lot. I again want to give credit to Drs. Fett and Carraway and the Albert Schweitzer Hospital, which was started in the 1950s by Larry Mellon of the Pittsburgh Mellon family. Here are a couple of pictures of the Artibonite River Valley and the front of the hospital, where you probably can't see it, but this is Reverence pour la vie, which is the famous Schweitzer book and saying that the reverence for life, and they do a wonderful job there. By the way, I also have to say that Dr. Carraway, who I introduced at the first, was also the first person to realize that cholera was taking place in Haiti after the earthquake. He had the very first case and thought this may be cholera, but that's a whole other story. It's a very interesting place. Dr. Fett also runs a blog and a website called Healing for a Mother's Heart, which a lot of us refer patients to get information, and it's definitely worth looking at. Has a lot of the IPAC data and a lot of other supporting data for women who are diagnosed with this problem. So thank you very much. I hope this has been interesting, and I'll be happy to take some questions.
That was fascinating. We have time for a couple of quick questions, I guess. So I'll start out with one. So is this a disease, or is this really sort of a syndrome? Is this multiple diseases that just are occurring in this patient group?
Yeah, I think I would agree with that. I think it's a syndrome, just like heart failure is a syndrome. I think there are many processes that can cause LV dysfunction, clinical heart failure, and decreased survival. There are probably several things, if not many things, that can make people more prone to developing heart failure with pregnancy, and I've tried to describe a few of those. Yeah.
Questions from anybody? And someone get Lindsay a microphone over there.
Thank you. That was a great talk. You alluded to a lot of the uncertainty that we deal with when treating these women. Do you think in the near future we might see a role for genetic testing to identify those women who have a genetic predisposition to dilated cardiomyopathy and may have a poorer prognosis to guide treatment?
Yes, I think that's a big topic. I think the cost of genetic testing in general for heart failure patients is going to be a decades-long thing. There are some women who have familial peripartum cardiomyopathies or may be at higher risk. So you could easily imagine maybe we should be testing some of these patients for markers like sFlt1, for instance, or other things. I think that the cost of genomic-wide screening is still in the several $100 range for idiopathic cardiomyopathy, and of course it's hard to imagine ever doing that in third world places where most of this disease afflicts. But I think that we're going to learn a lot about that, and hopefully we can get down to a few things. For instance, Titin. Seems like a fair number of people have sarcomeric mutations, and if we could identify some of those, whether it's familial or associated with some other risk, maybe they had a previous diagnosis of peripartum cardiomyopathy, maybe we'll have some of those biomarkers as we go forward. We would like to, just related to that, we would like to expand what we offer in the Atlanta community as far as genetic testing in general. And so I think that's a whole other topic, but some of that could include the peripartum population. Particularly since I'm at St. Joseph's and Northside is right next door where so many babies are born. So.
All right. Well, I think given the hour, we'll call it close there. And,
Okay,
but thanks so much, David. That was great.
The preceding program is copyrighted by Emory University.